Like they are not drugs that you hear their name on a normal day. You understand? They are drugs that are actually reserved for the crazy times. So these are drugs that are used for gene therapy. So apart from the drugs used for gene therapy, I also have some one or two presentations on the concerns of gene therapy. That's basically what makes it that gene therapy has not been globally approved yet. You understand? So, but it's more of the drugs. So anytime we come across those concerns, I also give it tip. Yes, so I think let me look for something. So place this on it. Okay. All right. So for the first drug which you'll be looking at is pharmacology as related to the gene therapy drugs. This is what is known as a alipogen tiparvovec. So like I was telling you guys, these drugs are not drugs that you see on a normal day in the hospital. Okay, they are only seen there based on demand. So the brand name for this is known as the Glibera. So let's quickly move into it. We said that alipogen tiparvovec, brand name Glibera, is a gene therapy treatment that delivers what a functional copy of what um, lipoprotein lipase using adeno-associated virus vector. Okay, and the main disease you use this drug in treating is a lipoprotein lipase deficiency. Right. So what's the pharmacology of this alipogen tiparvovec? So class and mechanism of action, we said at the type, is a gene therapy medicinal product. So what's the vector that is used in what? Delivering this drug to its site of action is what is known as the adeno-associated virus serotype 1. Okay, abbreviated as the AAV1. So gene delivered is human lipoprotein lipase variant. Okay, so mechanism. Um, this adeno-associated virus will introduce the functional lipoprotein lipase that this alipogen tiparvovec usually has. So when you deliver it into muscles, once it is inside the muscles, the gene is expressed under the control of a CMV promoter. So this will now lead to the production of a functional lipoprotein, what? Lipase enzyme. So this will now hydrolyze triglycerides in the chylomicron, reducing what? Hypertriglyceridemia. Because most patients having the lipoprotein lipase deficiency suffer from what? Hyper um, triglyceridemia. Okay, so once you reduce the triglyceridemia, it will reduce the risk of the patient having pancreatitis. So pharmacokinetics, they give it as intramuscular injection, distribution, so that the vector remains localized in the injected muscle. So it's just the muscle that is affected. You inject it directly there. Okay. Then expression. So long expression of lipoprotein lipase protein is possible. Okay, so that's it. So it's a gene therapy and all of that. Okay, so all those absorption, metabolism, excretion do not apply. Okay, it's just something that is more of like just going into your body and reasons why it is there. Okay, so that's what we got for that. So therapeutic use is used in treating what? Familial lipoprotein lipase deficiency. Okay, in patients that have severe or multiple episodes of pancreatitis. Okay. So adverse effects. What's the adverse effects? Where you injected it can cause injection site pain, muscle discomfort, headache, and fever. Right, and sometimes your immune could actually respond against that viral vector, okay, or the transgene. Sometimes can harm your liver, leading to elevated liver enzymes. So that's what we have for the first gene therapy drug we should be moving on. Now, for the next gene therapy drug which we'll be discussing is what is known as the Betibe glogene. Betibe glogene autotemcel. Okay, that's a Betibe glogene autotemcel. So the brand name for this is what is known as Zinteglo. Zinteglo. Okay. So what we have, the Betibe glogene autotemcel, also known as a Zinteglo, is an autologous gene therapy and is mostly used in treating what beta thalassemia. So just a summary, we said that it uses a lentiviral vector to insert a functional beta globin gene, okay, into the patient's own hematopoietic stem cells. Okay, so this will now enable the cells to keep producing functional hemoglobin. Okay, so I know the patients suffering from the beta thalassemia usually suffer from that issue where there's no functional hemoglobin. So class and mechanism of action is an autologous gene therapy. The vector it uses is the lentiviral vector encoding a modified beta globin chain, okay, known as the beta A T8 7Q. So what's the mechanism? So the patient hematopoietic stem cells are harvested. It's an ex vivo, so they basically do it outside. So ex vivo, it will be transfused to the lentiviral vector. So it's a vector that will basically what? Carry that functional beta globin gene. So once the functional beta globin gene goes into the hematopoietic stem cells, it now enables the cells to start producing what? Red blood cells that have what? A good hemoglobin. Right? So this will now correct the what? Bad hemoglobins that used to be produced when there's beta thalassemia. Okay? So they call that the ineffective erythropoiesis. Is to correct the ineffective erythropoiesis. So pharmacokinetics administration is a single intravenous infusion of the autologous CD34 cells after the myeloablative condition. Distribution modified stem cells will engraft in the bone marrow. So it has a long-term expression of the beta globin gene, right? So that's what we have. So therapeutic is mainly used in treatment of what? Beta thalassemia, but to be specific, you can say the transfusion dependent beta thalassemia. Of course, that's like literally beta thalassemia that we have been treating, transfusing blood, but you know, the disease still persists. So patients may achieve transfusion independence or marked reduction in their need for blood transfusion once they have this drug. Okay, so adverse effects can cause cytopenias, can cause mucositis, can cause febrile neutropenia, and the rest of it. So that's it for this gene therapy. Let's quickly move to the next presentation. Now, the next presentation, we're looking at another gene therapy drug. Now, for this gene therapy drug is what is known as the um, delandistrogene moseparvovec. It's also known as the LFVDs. Delandistrogene moseparvovec, also known as the LFVDs. So what we have here, we said that the delandistrogene moseparvovec is a gene therapy. It's approved for treatment of Duchenne muscular dystrophy. It uses an adeno-associated virus serotype RH74. Okay, and that's basically what takes the medication to the site of action. So it delivers a shortened but functional version of the dystrophin gene. That's what's also known as a microdystrophin to muscle cells. So that will now enable the muscle cells to keep producing what? Dystrophin protein that is very functional. So that's what will basically what? Slow down the Duchenne muscular dystrophy disease. So what's the class and mechanism of action? Drug class is a gene therapy. The vector it uses is what? The AAV RH74, also known as the adeno-associated virus serotype 74. So gene delivered is the gene that the drug has is a microdystrophin or a shortened dystrophin. So what's the mechanism of action? The vector will carry the microdystrophin gene to the muscles. So the cells begin to produce microdystrophin proteins. Okay, and that's what will basically tend to like slow down the disease condition. That's the Duchenne muscular dystrophy. So this will now compensate, you know, for the low levels of dystrophin or total absence of dystrophin that you usually see in what? Duchenne muscular dystrophy. So pharmacokinetics is a single intravenous infusion. The vector targets skeletal muscles and cardiac muscles and all of that. Okay. So the vector, after doing all the work, eventually degrades and the immune response may limit persistence. So therapeutic use is mainly used in patients that are above 4 years, okay, that have the Duchenne muscular dystrophy. Okay. So it improves the dystrophin expression to slow the disease and to enhance how strong the muscles are, okay, or how the muscles are functioning. So adverse effects is could cause vomiting, could cause fever, cause nausea, then decreased appetite. Right. So that's what we have for that. Let's quickly move to the next gene therapy drug. And for the next gene therapy drug we should be looking at is what is known as an hexagamglogene. Hexagamglogene autotem cell. So this goes with a brand name known as the Casgevy. Hexagamglogene autotem cell goes to the brand name Casgevy. So for what we have here, we said that the hexagamglogene autotem cell is a CRISPR-Cas9 based autologous gene therapy, and it's mainly used in treating sickle cell disease and also what beta thalassemia that has affected the person so much that the person is what literally dependent on blood transfusion. Okay. So class and mechanism of action is an autologous gene edited cell therapy. Technology uses the CRISPR-Cas9 genome editing to target it to actually enhance a gene known as the BCL11A gene, okay, in the hematopoietic stem cell. Okay. So how does the drug work? We said that the patient's stem cells will be harvested and be taken out. It's usually done in the lab, you know. So the CRISPR-Cas9 will now disrupt what the BCL11A erythroid specific enhancer. Okay, so this will now reduce the BCL11A expression. Okay, which is a repressor of what fetal hemoglobin. So edited stem cells will now be reintroduced back into the body of the patient. Okay, so engrafted cells will now be producing red blood cells with high fetal hemoglobin levels, which will now prevent sickling and to compensate for what defective beta globin. So this is how this gene therapy works. So pharmacokinetics is a single intravenous infusion. Okay, so they usually infuse CD34 cells after conditioning. Distribution edited stem cells will go into the various bone marrows. Okay, and blood will be produced and it has a high level of fetal hemoglobin. Okay, and it's a long-term expression of that. So durability depends on the stem cell engraftment. Okay, how much of the edited stem cells have actually gotten into the bone marrow. So therapeutic use in treating sickle cell in patients that have gone above 12 years, you know, transfusion dependent thalassemia in patients that are also above 12 years. Okay. So clinical impacts, most patients will achieve transfusion independence. Like they will no longer need, transfusions due to all those what do they call it? Due to all those crises. Okay. So adverse events can cause cytopenias, can cause mucositis, can cause febrile neutropenia. We'll look at the next gene therapy drug, and this is what is known as beremagene geperpavec. So they actually have all those weird names. So beremagene geperpavec. So the brand name is what is known as Vijuvec. Okay, so for the beremagene geperpavec, also known as the Vijuvec, it's a topical gene therapy. Is based on a replication defective what herpes simplex virus type 1 vector. Okay, so it uses the herpes simplex virus type 1, but that herpes simplex virus type 1 that has been used in transporting it has been weakened. So it can't really replicate, it can't make other copies of itself. You know. So, what's the class and mechanism of action? It's a topical gene therapy, and it uses what? Replication defective herpes simplex virus type 1. So, what's the gene delivered? It has a gene known as a human what? Col7A1 gene. Okay, fully known as a collagen type 7 alpha 1 chain. Okay, so what's the mechanism of action? So the herpes simplex virus, that's the replication defective one. Once it delivers this gene into keratinocyte, those are cells that make keratin, and also fibroblasts, the cells begin producing functional type what? 7 collagen. So this collagen forms anchoring fibers at the dermal epidermal junction. So this is what usually restores skin integrity and reduces what? Blister formation. So you might want to actually ask, okay, we'll get to talk about the different disease conditions that we use this drug in. But for the pharmacokinetics, you should know that mainly the drug is in gel. Okay, they apply it on the gel. You know, absorption is just where you actually what? Apply it. Okay, localized treatment to the skin. So vector remains at the application site and does not replicate or spread. Okay. So expression of the COL7A1 protein supports wound healing. Okay. So that's what we got. So therapeutic use, treatment of wounds. Imagine in patients more than 6 months you can use them. Okay. So it's mostly advised in patients that have all those dystrophic epidermolysis bullosa, okay, caused by mutations of the COL7A1 gene. So it improves wound closure, reduces blisters, enhance the quality of life. So adverse effect can cause itching, can cause chills, can cause rashes, can cause redness at the application site. So that's what we have for the beremagene geperpavec, also known as the Vijuvec. Right. So let's quickly move to the next gene therapy. Now, for the next gene therapy which we'll be looking at, the name is what is known as the cambio gen plasmid. Cambio gen plasmid. So the brand name here is what is known as the neovascul Cambio gen plasmid, also known as neovascul. So it's a gene therapy usually is used in Russia for the treatment of peripheral artery disease and sometimes even limb ischemia. Okay, so drug class is a gene therapy drug, but it's a plasmid DNA based type. The vector it uses is a non-viral plasmid DNA. Gene delivered is a gene known as a human what? VEGF 165 gene, and the VEGF of course is the vascular endothelial growth factor. Okay, so usually what inject this drug into the muscles, so it will deliver the plasmid DNA into the muscle cells. So cells will express what? The VEGF 165 protein. Now that's a protein that is actually what? The actually what? Vascular endothelium. So vascular is blood vessels. So it actually what? Encourages blood vessel growth. So that's a potent what? Angiogenic factor. So it promotes endothelial cell proliferation, migration and formation of new blood vessels. Okay, so this will now enhance circulation. It will improve oxygen reaching the tissues and all have you. Okay, so pharmacokinetics is intramuscular injection. Okay, at the site affected, so there will be local uptake by the muscles. So and all of that. So this transient gene expression, repeating dosing is usually what's required. So that's what we have, right? So mainly it's used in treating what? Peripheral artery disease and also limb ischemia, just to improve blood flow again by formation of new blood vessels. Okay, so that's what we have for this. Uh, Now, just like I told you guys, we'll be talking about the gene therapy drugs, and we'll also be talking about some disadvantages of gene therapy or some things that make gene therapy kind of like a concern, something that you can't really give it 100% mark. So, here we want to actually talk about the drawbacks to gene therapy. What are the things involved in gene therapy that you feel they are not really ethical? You understand? So gene therapy offers a lot of good things. We say that it's a groundbreaking potential, but just like with every good thing, usually have disadvantages. Okay, so there's safety risks, and one of it is very expensive. So let's look at the drawbacks. First is the safety risk. So sometimes if you put a gene therapy into somebody's body, the person's body could kind of like react adversely to the gene therapy. You know, and sometimes it can even harm the DNA of the individual. Okay, so high doses of the vectors or high doses of gene therapies could also damage the liver, could damage the kidneys, damage a lot of organs in the body. High cost. You should know that it's very expensive. For example, treatments like the Roctavia, that's for hemophilia A, it's about $2 to $3 million. Okay, so it's very expensive, and accessing it is not really easy like that. Okay, so technical complexity. So it requires advanced technological facilities, specialized viral vector production, highly trained professionals. It's not every doctor that could actually carry out gene therapy. Do you understand? So it makes it kind of like special to do it. It's kind of like hard and the rest of it. Limited effectiveness. So not all patients that will undergo a gene therapy will now go so well. Do you understand? So sometimes the same disease condition could come back again. That's what we call a relapse. You know. So ethical concerns, so sometimes if they do a particular gene therapy to you, you might end up passing it to your future generation. Now, your future generation didn't actually authorize that. So there's a whole lot of ethical, you know, concerns about that is not really ethically right. You understand? Regulatory challenges is globally people have different insights to gene therapy. So the way gene therapy is, the controversy is at the same level with abortion. You know, people say it's right, people say it's wrong. Everybody has their their there are stories to prove. People handle it with culture, people handle it with religion, and it's just still there. So these are the various drawbacks, or you could say disadvantages to gene therapy. Now, the next discussion we'll be making, we're talking about the next, we'll talk about the next gene therapy drug, okay? And this is what is known as the etranacogene dexaparovec. Okay, etranacogene dezaparvovec. So this is has a brand name which is known as Hemgenix. Has a brand name known as Hemgenix. So for what we have here, we said that it's actually a gene therapy and it's mostly for treatment of what? Hemophilia B. Okay. So what is it? The drug class is a gene therapy. What is a vector? It uses to transport what? The effective material in it. It uses the adeno-associated virus serotype 5. That's the AAV5. So what's the gene that that drug carries? It carries a human factor 8, okay? Okay, also known as a fixed Padua variant, also known as R33-8L mutation. So mechanism, the vector, that's a virus, would deliver the fixed Padua gene, that's what, the factor 9. Okay, sorry, this is 9. Sorry, this is 9, right? It will deliver the factor 9 to the hepatocytes. Hepatocyte will now begin producing what? The fixed protein. That's a factor 9 protein. I'm calling it fixed because it just looks like fixed, but it's F9. Okay, so that's a factor 9 protein. The factor 9 protein will now be circulating in plasma. So the factor 9 Padua has 8-fold higher activity than the normal type of factor 9 that you have, in the body. So you are suffering from hemophilia B, your body is not clotting, your blood is not clotting well, you are bleeding anyhow. So because you have a lot of factor 9 replacement now, it will improve your clotting. Okay. So pharmacokinetics, usually intravenous infusion, single. The vector targets the hepatocyte and expression can last for years. Just a single infusion of the drug can actually protect you for years. Okay, so therapeutic use mainly for treating hemophilia B, which is what simply the deficiency of factor 9 in the body. Okay, so patients may achieve sustained factor 9 levels. Okay, and this is what actually prevents what they bleeding anyhow. You know, patients suffering from hemophilia B could just bleed spontaneously. So adverse effects could damage the liver, causing elevated liver enzymes, could cause headache, could cause flu-like symptoms, and sometimes infusion-related reactions. Okay, so that's what we have about this beautiful drug used in treating hemophilia B. Now let's quickly move to the next drug. Now, for the next gene therapy drug we should be discussing, the name of the drug is known as the brexucabtagene autoleucel. So most of these drugs they have a lot of weird names because that's why I was telling you guys that it's not things that I just ordinarily see in the pharmacy. Let's go over the name again. Brexucabtagene autoleucel. The brand name is known as a Tecartus. So it's an autologous CAR T cell therapy, usually targets the CD19. It's approved mainly for the treatment of mantle cell lymphoma and also the acute lymphoblastic leukemia. Okay, so what's the class and mechanism? It's an autologous cellular immunotherapy. It targets the CD19, which is a surface antigen expressed on B cells, so that the patient's T cells are collected via leukapheresis. Then it is outside. So it's outside in the lab. You basically what transduce with a retroviral vector encoding a CAR construct. So the CAR construct is an extracellular, it contains what? An extracellular domain recognizing CD19, a CD3 zeta signaling domain for T cell activation, then a CD28 co-stimulatory domain for enhanced proliferation and persistence. So after the infusion, the CAR T, that's it will now bind to the CD19 cells, right, to activate, proliferate, and induce cytotoxicity. So this will basically reduce the levels of B cells. Okay, it will reduce the levels of B cells. So that will basically like slow down the mantle cell lymphoma and the acute lymphoblastic leukemia. Those are the ones that basically they depend on B cells to keep proliferating. So pharmacokinetics, a single intravenous infusion, okay, and CAR T cells expand in vivo, peak within 1 to 2 weeks, then decline. Okay, so that's what. So therapeutic use is mainly for treating mantle cell lymphoma and also what the B cell precursor acute lymphoblastic leukemia. Okay, so that's what we got. Adverse effects can cause cytokine releasing syndrome, can also cause some issues to your nervous system, make you to be confused, to have seizures, encephalopathy, and all of that. All right, so that's it for the Brexu captagen. autoleucel. Now we'll pause here and here we'll get to look at another reason to why gene therapy is not being accepted worldwide. Okay. Now another reason to this is what is known as gene doping. So if I will give you a little story about what gene doping is, gene doping is simply if I know that I could be able to do gene therapy and edit my genes, I'll now edit my genes in a way that I'll be a genius. Let me say in sports, I'll edit my gene in a way that I can run very fast as a footballer, as an athlete, and I'm winning Olympics, medals, and all of that. And it's fake because it's not the real me. My genes were edited to make me a genius. Do you understand? So this is one of the reasons, this is one of the concerns to gene therapy. So gene doping, just so you know, is one of the most controversial concerns linked to gene therapy, especially in sports. So while gene therapy is designed to treat genetic diseases, it can also be used to edit someone's genes in a way as to what improve their performance. Do you understand? So gene doping is what the non-therapeutic use of what gene therapies to enhance physical performance. Mechanisms involves insertion or modified what genes. So they increase things like muscle growth, endurance, how you can handle oxygen in the body, and the rest of them. So examples: erythropoietin gene, if they edit it, it will boost red blood cell production, it will improve oxygen delivery. So such a person is running, 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 running without getting tired. Insulin-like growth factors can promote muscle growth and repair. Okay, myostatin inhibitor can remove natural limits on muscle size. So you are just growing, growing, you are very large, you are lifting weight and all of that. So concerns about gene doping is health risks. It could actually lead to, it could be beneficial in the first place, but later on lead to issues. You know, so it could cause cancer, organ damage, destruction to your immune system. So ethical issues evaluate the principles of fair competition in sports. Everybody should actually compete in the natural form. Could pressure athletes to undergo risky procedures. So other people too are trying to pay back because you cheated them, you got a medal, they're trying to pay back, and the whole issue escalates, okay? So it blurs the line between therapy that's restoring health and cheating. Okay, so this one you're basically using a very good thing to cheat. So dictation challenge. If somebody uses drugs to enhance their performance, I can test their blood, and dictate the contents of the drug in the blood. But if there's gene therapy edits, it's very hard to what pinpoint it. Okay, so that's what we have. So basically, especially in sports, they are very very against what anything gene doping. Okay, they don't like gene doping. Okay, so we're looking at another concern to gene therapy. Okay, so death as a major concern to gene therapy. So this death as a major concern to gene therapy is uh, what? It just simply has to do with some patients could actually undergo the process of gene therapy and they die of it. Okay, it's just as simple as that. So gene therapy carries what significant promises, is a very nice thing, but death is actually one of the concerns. So for example, several children under 5 died in what Astellas trial for X-linked myotubular myopathy after developing liver dysfunction. That's after they were treated with a drug that they were testing. A 16-year-old boy with Duchenne muscular dystrophy died of acute liver failure after receiving what LVDs, which is a gene therapy that we even discussed in pharmacology. So death is actually one of the concerns of people that want to undergo gene therapy because you can go in, but there's no guarantee that you come out after the gene therapy. Okay. So underlying mechanisms is Sometimes your immune system could overreact to the gene therapy that was put into your body. Most of those gene therapies they use viruses to transport the medication. So sometimes your body could actually misinterpret the issues on ground and react adversely. They could also be so toxic to your liver, that's liver toxicity. Then insertional mutagenesis. So sometimes where they are inserted, they can damage the DNAs or other genes in that place. Okay. So we said that the Food, Drug Agency and other agencies have held public meetings to address these risks, emphasizing strict monitoring and patient selection. And of course, if you're undergoing gene therapy, you should be with somebody that is very much more trained for the course. So that's what we have for this gene therapy as a major concern. That's death as a major concern to gene therapy. Now we'll move away from the concerns and we'll talk about the next gene therapy drug. Now, for the next drug we are talking about is what is known as the elivaldogene autotemcel. So elivaldogene autotemcel is also known as the Skysona. Okay. So Sky Sonar, we said that it's an autologous gene therapy. It's mostly used for treating what? Cerebral adrenoleukodystrophy. So let's talk about its pharmacology profile. The drug class is an autologous gene therapy. What's the vector that it uses? It uses a lentiviral vector encoding the ABCD1 gene. So it delivers for the ABCD1 gene. So ABCD1 is also known as the ATP binding cassette subfamily D member 1. So mechanism, patient hematopoietic stem cells will be harvested. So ex vivo. So they are now transduced with the lentiviral vector, okay, that carries the ABCD1 what gene. So after reinfusion, the stem cells will now what? Engraft into the bone marrow and differentiate into the monocytes and macrophages. So these cells will migrate into the brain and produce what? Adrenoleukodystrophy protein, okay, which restores the peroxisomal transport of very long chain fatty acids. So that's usually what slows down demyelination and neurodegeneration that you have in cerebral what? Adrenoleukodystrophy. Okay, so pharmacokinetics, single intravenous infusion of autologous CD34 after mayo ablation. So distribution, modified stem cells will go into the bone marrow, differentiate into monocytes and what? Macrophages, then move to the brain. Do you understand? So that's what will now make that the adrenoleukodystrophy protein is now continuously being produced just to slow down the disease condition. So the drug is mainly used in treating what? Cerebral adrenoleukodystrophy, mainly in boys, age 14 to 17. So that's basically it. Adverse effects can cause cytopenias, mucositis, febrile neutropenias, and the rest of it. Okay, so that's what we have for this. Now let's quickly move to the next drug, which we'll talk about its pharmacology. Now for this next one is what is known as a stream velis, pharmacology of stream velis. So for the stream velis drug, um, we said that it's actually an autologous ex vivo gene therapy. That means you have to bring out the hematopoietic stem cells outside and you do everything within the lab before you infuse it back into the patient. So it's usually used in Europe for treating what? Adenosine deaminase deficient severe combined immunodeficiency. Will describe everything. So it's simply known as a bubble boy's disease. Bubble boy's disease simply means the patient has to be kept within a confinement because their immune system is so weak to the extent that once they just get in contact with the world, they take an infection. Okay, so class is an autologous gene therapy, uses a retroviral vector encoding the ADA gene. So that's what the adenosine deaminase deficiency. Okay, like that. Okay. So patient hematopoiesis stem cells will be harvested from the bone marrow. So while in the lab, they'll be transfused with a retroviral vector carrying the ADA gene. So after reinfusion, the stem cells will engraft and differentiate into what immune cells. So that's what will now make it that the immune system of that fellow would actually keep becoming stronger. So these cells will express the other enzymes which detoxifies the deoxyadenosine metabolites. So with all these processes, the immune system function of that person will be restored. Okay. So pharmacokinetics usually a single intravenous infusion of autologous CD34 cells, you know, modified stem cells were engrafted into the bone marrow, and that's what basically starts making up good immune system and all of that, you know. So therapeutic use, I've spoken about it, used in treating bubble boys disease. So clinical impact, it provides both long-term immune support, so to make the immune system of the patient very strong for a very long time. So adverse effect can cause cytopenias, can cause fevers, mucositis. Okay, so that's what we got for this. Stream valleys. What we got for stream valleys. So let's quickly move to the next drug, which we'll talk about its pharmacology. Now, for the next drug, which we'll be discussing its pharmacology, we'll talk about what is known as a onasemnogene abeparvovec. Onasemnogene abeparvovec. So the brand name of this drug is what is known as Zolgensma. Okay. So onasemnogene abeparvovec is a gene therapy usually approved for treatment of what spinal muscular dystrophy in pediatric patients. That's mostly in children. Okay. So drug class is a gene therapy. Okay. What is a vector? Okay. What actually transport the drug to the site of action is the adeno-associated virus serotype 9. So what's the gene that this drug has to come and replace what is missing? Is what is known as the SMN1 gene. That's the survival motor neuron 1 gene. Of course, that's the gene that will code for the survival motor neuron protein. We'll talk about what it is. So what happens? The vector, that's the adeno-associated virus serotype 9. It crosses the blood-brain barrier. It transduces the motor neurons. So it carries the gene, right? So that's the survival motor neuron 1 gene. Okay, so it's expressed what? The gene is expressed what? Episomally, and it will start producing the survival motor neuron protein. Okay, so the protein is what will now restore how neurons are surviving in the body and how neurons are functioning. So that's what will now reduce the spinal muscular what atrophy disease condition. So this is how these drugs work. Okay, so pharmacokinetics is just the same thing. The adeno-associated virus will basically, take the gene there, and it's a single intravenous infusion and all of that. Okay, so vector DNA eventually degrades. The immune responses may limit persistence. Okay, so therapeutic use mainly used in treating what spinal muscular atrophy. So it improves motor function. That's basically the effect. Improves motor function, reduces risks of all those respiratory distress. Okay, then what next? So adverse effects can cause elevated liver enzymes, can cause vomiting, and can also cause what? Fever. Alright, so that's what we have for this drug. Let's quickly move to the next gene therapy drug. So for the next gene therapy drug, we're looking at what is known as a valoctocogene rosaparvovec. That's the next drug we're looking at. So the brand name of that drug is what is known as a Roctavian. Roctavian. So for this drug, we said that it's a gene therapy is mainly used in treating what? Hemophilia A. Okay. So The drug class is a gene therapy. What's the vector that this drug uses to actually transport it to the site of action? It uses the adeno-associated virus serotype 5. Okay, so what gene does this drug has? You know, in hemophilia A, you are lacking the factor 8. So this drug has what? The factor 8 gene. So once the factor 8 gene gets into you, it will now what? Make plans so that what? More factor 8 is produced. So this is what will now reduce the bleeding that people with hemophilia A will usually suffer from. So the adeno-associated virus serotype 5 delivers what? Factor 8 gene to the hepatocyte. So the hepatocyte will now start producing factor 8 protein, which circulates in plasma. So it's the factor 8 protein that basically what becomes the factor 8. And this will now what? Start taking your clotting cascade accordingly. And this will now reduce what? Bleedings that people with what hemophilia A, that's factor 8 deficiency, will be suffering from. So basically, the drug is more of like what a factor 8 replacement therapy. Okay, so usually give it a single intravenous infusion. The vector targets the hepatocyte, and the rest of the beautiful story, which will lead towards the production of factor 8. So therapeutic use mainly used in treating what? Hemophilia A. Okay. Adverse effects can cause elevated liver enzymes, can cause headaches, can cause nausea, can also cause fatigue. So that's what we have for this drug. We'll move to the next drug, which we'll be discussing is okay. So the next one is not a drug. We're basically discussing, ethical issues as related to gene therapy. Okay, so here we just want to look at a code of conduct in medicine that basically guides how medical providers should treat patients. This is what is known as a Helsinki Declaration. Okay, so it's a statement of ethical principles that basically guide medical research. Okay, if you want to do a research, what are the principles that should guide you? You don't just go take patients, start doing research and all of that, right? So there's a code of conduct for doing research in medicine. So the Declaration of Helsinki, you should know that it's a cornerstone document of medical research ethics. Okay, so it sets out principles to protect human participants. If you are trying to do a clinical studies that should involve humans, this should actually guide you on how to, conduct everything. So the first principle is respect for humans. So research must prioritize the health of the humans participating in the research, must prioritize their well-being and also their rights. So informed consent is very essential. So for the people participating in the research, you must actually tell them everything that will happen, and they must actually willingly agree. Okay. Scientific integrity. So research should be scientifically sound, based on thorough knowledge of the subject, and conducted by qualified professionals. Risks throughout the research should be greatly minimized. Vulnerable population. So extra protections are required for groups with limited autonomy. That's children, prisoners, economically disadvantaged. So sometimes the government might just want to pick some group of people to do a research, but in as much as those people don't have a no to say, you must actually what? Still protect them throughout. So they are vulnerable before you, but you still protect them throughout the process. Transparency and accountability. So clinical trials protocols must be registered publicly before recruitment begins. So that means the healthcare associations in that place must actually approve your research before you go on. So the results after the research, whether positive or negative, should still be published. Okay. Fairness and equity. So research should be conducted with fairness, avoiding exploitation of any group that is involved. Oversight and review. Independent ethics committees must review and approve research protocols. Researchers must comply with both local laws and international laws, okay, that have to do with what we're making research. So with all this, this is what is known as a Helsinki. Okay, it's Helsinki. Okay, Helsinki Declaration. Okay, and this is what actually guides all the ethics that's as related to medical research. Okay, so this is what we got, and we are progressing. Now we are looking at another concern to gene therapy, and concern to gene therapy is more of like a disadvantage, okay, to gene therapy, and this is insufficient knowledge about the possible risks of the gene therapy somebody is having now. So the risks that that gene therapy will have on future generation, the person doesn't really have sufficient knowledge for that. So that's a disadvantage to gene therapy. Okay. So sometimes you are correcting something in your body, but when you give birth to children, you might actually push that into the children. Now those children didn't actually give permission for that. So that's actually one of the ethical concerns in gene therapy. So the long-term risks of gene therapy to future generations sometimes are understood, but just a little. They are not fully understood, you know. So it raises serious concerns, okay, because gene therapy alters DNA, and sometimes you can now push some unintended issues to the future generation. While you are dead and have passed away, they'll be there suffering from it. So why future generations are a concern is germline and somatic therapy. So somatic therapy affects only the person that is being treated. But sometimes if you correct something for the germline, like altering the sperm, the egg, the embryo, it can now affect the people that come in at the back. Okay. So insufficient long-term data. So most gene therapy trials are recent. So multi-generational effects have not been recorded. Like most gene therapies, right, is the 21st centuries that we started having them. Most drugs have been approved this 21st century. So we can't really make reference to data that has been there 100 years ago. Most data that have been there are young data, just 10 years old. Can't really make reference to old data. So what next? Unpredictable genetic interactions. Well, modified genes may interact with other genes differently in future generations. You have not been to the future, you don't know what is happening. Okay. Then ethical and social concerns. So consent across generation. Future individuals have not actually gave you a permission to alter something in them. Equity issue. So if gene therapy is expensive, only wealthy families may access it. So is not equal. The equality there is not it. So if this gene therapy is something that must be feasible, then it must have to actually make it cheap. Designer babies debate. So concerns that gene therapy could be misused for enhancing and giving birth to perfect babies later on. The baby is 100% intelligent, the height is 100% okay, the person is an athlete, the way they are running is 100% good, the way they are playing football is 100% good. Now, this will not be nice, okay? So, reduce diversity. So, because you are giving birth to, how will I say, you are giving birth to people that are perfect, there will be reduced diversity in the world, okay, which will not be nice, okay? So, all of these are usually what disadvantages of gene therapy, okay? And they actually raise concerns to if this should be globally approved or not. Now, having spoken about some concerns, we'll move to some drugs again. Okay, that's the grind. Now, for the next gene therapy drug, we'll be talking about what is known as a nadofaragine, firadenovec. Nadofaragine, firadenovec is also known as the what? Alstiladrin. Okay, so it's a gene therapy. Okay, nadofaragine, firadenovec, alstiladrin. So what we have is that gene therapy is approved for treatment of non-muscular invasive bladder cancer. So drug class is a gene therapy. What's the vector that it uses? It uses a recombinant, non-replicating adenovirus serotype. So what's the gene that this drug contains? It contains what? The human interferon alpha 2b. So how does it work? It's instilled directly into the bladder via a catheter. Then the adenovirus transduces what? Urothelial cells, leading to local expressions of the interferon alpha 2b. So it's the interferon alpha 2b that what enhances immune-mediated direct destruction of bladder cell cancers. So the interferon alpha 2b, once it comes in, it makes your immune system very strong so that your immune system can what? Kill the cancer cells. So to say, he said that what? The interferon alpha 2b activates the natural killer cells. Those are the cytotoxic T lymphocytes. Kill the cancer cells more. So pharmacokinetics, they give it in the bladder directly. Absorption is just locally within the bladder. Distribution is locally within the bladder. Therapeutic use mainly for treating what? Non-muscular invasive bladder cancer. So what's the adverse effect? Can cause fatigue, bladder spasms. When you urinate, it's painful. When you urinate, there's blood in urine. There's urgency and there's chills. So please, if you come and watch this video, this happens to be very small, but my bad. I hope you guys could still see it. Okay. So therapeutic use. Okay. So the same thing here that I actually brought here. Okay. It was supposed to be the pharmacokinetics only here. So the therapeutic use and the adverse effects are actually here. All right. So that's what we got for this. And let's quickly look at another disturbing thing concerning gene therapy that makes it that gene therapy is not something that has been accepted worldwide yet. So this is genetic enhancement. So genetic enhancement is actually one of the disadvantages of gene therapies. Why? Because if everybody has their hands on gene therapy and everybody is now editing their genes, you have only perfect people in the world and there will be no diversity in the world. Okay? So genetic enhancement is actually one of the debated concerns surrounding gene therapy. Why? Because it blurs the line between using gene therapy to treat disease, which is very nice, and it also blurs the line to using these gene therapies to make a lot of cheats, okay, editing and giving birth to perfect human beings and the rest of it. So gene therapy is usually something that was brought in to correct genes that are bad so that it can actually keep out disease. Genetic enhancement now, you can still use that gene therapy to improve a human being so that the human being is very intelligent, their strength is very nice, as for athletes, the way they endure is very nice, their appearance will be very beautiful and all. So that's is going beyond the reason why the gene therapy was made, just to treat disease. So what's the ethical issues? Fairness. Enhancement could create a lot of inequality, giving advantages to those who can actually afford that gene therapy. So how about the people that cannot afford the gene therapy is looking more of like a bias on their side. Consent. Well, parents may actually decide to edit the genes of their children, but did the children actually give permission for that to be done? That's another thing. Identity altering traits may affect how individuals identify themselves. Okay, so everything will not be authentic again. So social risks, designer babies, this is when you're now giving birth to perfect children due to gene editing, which would not be nice. Okay, discrimination. So for people that are not able to afford the gene therapy, they will be so low in the society and be so discriminated. So there's lots of diversity. Now, because of gene therapy, if people's genes are being edited and all of that, you are having perfect human beings on earth, there'll be lots of diversity. Okay, we need people in all aspects of the society. Okay, so scientific and medical risks is unpredictable outcomes. So gene can interact in complex ways, enhancing one trait could actually harm another trait. Okay, so long-term effects. So most of these therapies are actually new therapies. So basically, you don't know the issues that future generation will now come up with. So most countries have banned the germline genetic enhancement, but they allow it that you can actually be able to use a somatic one, which is what just treating cells to treat disease conditions. Okay, so that's what we got for this gene genetic enhancement as one of the reasons why gene therapy has not been accepted worldwide. Now we're looking at the next drug right here before us. So for the next drug which we are looking at, it's pharmacology. That's a gene therapy drug. This is what is known as a T-cell Lec-Lucel. So T-cell Lec-Lucel is also known as a Kimbria. That's a brand name, Kimbria. Okay. T-cell Lec-Lucel. So it's actually a CD19 directed autologous CAR T cell therapy. It's approved for treatment of what B cell malignancies. So the drug class is an autologous cellular immunotherapy. It usually targets CD19 cells, CD19 antigens or so, which are actually surface antigens on the B cells. So what's the mechanism? The human T cells will be collected out, so they will now be mixed with the drug. Okay, so you mix them with the drug. Why? Because you want the T cells to actually become stronger, so that when you reintroduce them back into the body of the patient, they can fight disease more. So this one is more of like it's strengthening the immune system. So an extracellular domain binding CD19 is CD3 is that's a CAR, the constituent of the CAR. So CD3 zeta signaling domain for T cell activation. Okay, so these are all the components that basically lead to what strengthening and activating a lot of T cells in the body. Okay, so that's what to now what recognize CD19 positive malignant B cells, and that what to now initiate cytotoxicity on those cells. Okay, cytotoxicity is like breaking down the cells of the cancer. So pharmacokinetics, a single intravenous infusion is usually enough. The CAR T cells expand in vivo, okay, and at least you start seeing them start working in around 1 to 2 weeks, okay, and their work would actually persist for a lot of months to a lot of years. So that's what we got. So therapeutic use mainly for treating what B cells, lymphomas, okay, diffuse large B cells lymphoma, acute lymphoblastic leukemia, okay, refractory follicular lymphoma, and the rest of them. Adverse events can actually cause cytokine release syndrome, and it could also be toxic to your nerves, causing confusion, causing seizures, then also the encephalopathy. So that's what we got for this particular drug. So I think let me get my windows opened. Oh, I'll make you do me one dance. Yeah. So I think I also need my phone plugged. I think we just have few presentations to be done. Not much again. Eba mi call. I'll make you do me one dance. So I think we're almost done. Now for the next gene therapy drug, which we'll get to discuss, this is what is known as the name of the drug. It's known as a Lovo T-Beglogene autotem cell. So the brand name is also known as what? The Live Genia. Okay. Lovotibeglogene, also known as Autotemcel, Live Genia. So it's an autologous therapy. It's mostly used in treating what? Sickle cell disease, sickle cell anemia. So the drug class is an autologous gene therapy. What's the vector it uses? It uses a lentiviral vector encoding HBA-T87Q, which is a modified beta globin gene. Okay, so how does the drug work? First of all, you have to harvest the patient's stem cell outside. You now mix it with the drug. So after you mix it, you now what? Reinfuse the stem cells back into the patient. Okay, so the stem cells will now engraft into the bone marrow, get used to the bone marrow. Now, from there, right, any blood that will be produced will contain a lot of what? HBAT87Q. So that's basically something that usually reduces what? The red blood cells from sickling. Okay, so when you use this in sickle cell disease, it will reduce a lot of what? Sickling in the patient. So to reduce all the crises, hemolysis, vaso-occlusive crisis, and organ damage are usually associated with sickle cell disease. Okay, so pharmacokinetics, okay, distribution is just usually in bone marrow, and there's a long-term expression of the HbA T87Q. So for a long time, the sickle cell patients will actually what? Be free from their blood actually getting sickled, you know. So therapeutic use is mainly used in treating sickle cell disease, but in patients that have actually gone above 12 years or already 12 years. So when used in such patients and there's reduced what? Episodes of blood sickling, okay? So they are usually free from blood transfusion, okay? So it can cause cytopenias, can cause mucositis, can cause febrile neutropenia. That's basically the adverse effects, okay, of this. So that's what we got for this very one. Let's quickly move to the next row. All right. Okay, so now for the next drug, we are looking at a drug which is known as the gendicine. Okay, gendicine. So gendicine, just so you know, is the first approved gene therapy drug in the world, and this was approved in China, 2003. It's a recombinant adenovirus carrying the wild type P53 gene, tumor suppressive gene. Okay, usually used to treat head and neck squamous cell carcinoma and other cancers. Okay, so let's talk about it. The drug class, the gene therapy, what's the vector it uses? That's what actually transports the drug to the site of action. It uses what? The recombinant human adenovirus serotype 5. Okay, the gene delivered is a wild type T53 gene. Okay, so mechanisms, most cancers will usually what? Inactivate P53 gene or mutate the P53 gene. So the gendicine will now still deliver what? P53 gene that is well activated and functioning. So once you have P53 gene that is well activated and functioning, is what actually what will now make the cancer cells to be dying off. Okay, and basically to make it that if you give chemotherapy to such a patient or radiotherapy to such a patient, it will affect those cancer cells more because there's P53 gene. Now, okay, that's just basically it. So the injection is usually what? Intratumoral injection. So you just inject it directly into the tumor. Okay, so the tumor cells there will locally take it up. Okay, distribution is just confined within that area, okay, where you had the issue. So it's mostly used in treating what? Head and neck squamous cell carcinomas, okay, and some other solid tumors in the lungs, solid tumors in the liver, solid tumors in the ovaries. We also use this drug in treating them. So what's the adverse effect? Can cause fever, flu-like symptoms, and just injection sites in pain, all right, just where you actually injected it, all right, and all of that. So let's quickly move out to the next. We're looking at the next drug right here before us. Now, for the next drug right here before us, this is what is known as a talimogene laherparvec. So they have wild names, Limlegic, that's basically the brand name. So the talimogene laherparvec is an oncolytic viral immunotherapy usually approved for treatment of melanoma. So it's a genetically modified herpes simplex virus type 1, okay, and it's designed to selectively replicate in tumor cells, okay, and basically kill the tumor cells, right? So it's an oncolytic viral immunotherapy. You are putting some virus into the body of the patient, but this virus will selectively what go to multiply in tumors and it will end up killing those tumors. So what's the vector it uses? Modified herpes simplex virus type 1. So mechanism of action, the virus will actually what go into the tumor cells, will grow into the tumor cells and will break the tumor cell down. So there's also release of tumor antigens to stimulate the systemic anti-tumor immunity, okay, and the rest of it. So pharmacokinetics, you inject it directly into the tumor. So it says there's intratumoral injection. Okay. So the virus will now be replicating locally within the tumor. So that's what will actually lead to what the death of the tumor. So there's minimal systemic spread. It's just within the tumor, right? So it's mainly used in treating all those cutaneous lesions, subcutaneous lesions, melanoma. Okay. So you usually shrink the tumors. Once you inject it into the tumor, it grows into the tumor, breaks it down, so it shrinks the tumor, right? So it can cause weakness, can cause chills, can cause fever, flu-like symptoms, injection sites, pain. That's basically the adverse effects for this. Now I think we're almost done. Almost done. Okay. So we still move to the next group of drug. Now for the next drug we should be discussing, that's the next gene therapy drug we should be discussing. It's what is known as the axicabtagene. So azicaptagene ciloleucel, that's the full name of the drug. Now the brand name for this drug is what is known as the Yescarta. So the azicaptagene ciloleucel is a CD19 directed autologous CAR T cell therapy. It's approved for the treatment of what? B cell lymphomas in general, okay, mostly the ones that have relapsed or refracted. So what's the drug class? Is an autologous cellular immunotherapy, that's a CAR T. It targets a CD9, which is what the protein or antigen expressed on B cells. Okay. So how does this drug work? The patient's T cells are brought out. You mix them with this drug. So what usually targets the CD19, right, is what will now what activate the T cells. So just get the story. When you mix the person's T cell with this drug, it activates a lot of those T cells. So once T cells are activated, they make your immune system very strong because T cells are cytotoxic. So when you reinfuse those what T cells back into the body of the patient, then they can now fight cancer cells better. Okay? So when you reinfuse them back, they recognize what CD19 positive malignant B cells and to induce the breakdown of those cells, or you say it induces what? Cytotoxicity. So pharmacokinetics is just single in a infusion. And you see that to start working in about 1 to 2 weeks. Okay. It's mostly used in treating refractory large B cell lymphomas, used in treating what? Mediastinal large B cell lymphomas, relapsed or refractory follicular lymphomas, and the rest of it. Okay. So adverse effect can cause cytokine release syndrome and can be toxic to your nerves, cause you to be confused, have some seizures, and also encephalopathies. Okay, so that's what we got for the azicaptogen cell. So let's quickly check if we still have some drugs left. Yeah, I think we actually have. Now we'll move to the next drug, okay, which we'll be discussing. And for this next drug is what is known as a ciltacabtagene autoleucel. Right? So most of these gene therapy drugs they actually have weird names. Okay, so you usually see them just based on what order. It's not things that you can just easily walk into the pharmacy and see them. So this is what is known as the ciltacabtagene autoleucel. So we say that this one too is a B cell maturation antigen directed autologous CAR T therapy. It's mostly used in treating refractory or relapse multiple myeloma. So this one is multiple myeloma. So what's the drug class? Autologous cellular immunotherapy. Target is B cell maturation antigen. Okay, that is usually expressed on what malignant plasma cells. So how does it work? The patient T cells will be collected outside to the lab. So they are transduced with a lentiviral vector encoding a CAR construct. That's basically they are mixed up with the drug. You understand? So um, they basically enhance the T cells. Okay. So when these T cells are reintroduced back into the system of the body of the patient, they recognize myeloma cells. Okay, and they kill the myeloma cells. That's just the story there. So a single infusion, they start working in about 1 to 2 weeks. Okay, mostly is in treating relapse or refractory multiple myeloma and the rest of that. So it provides durable responses in heavily pretreated patients with a high rate of minimal residual disease negativity. So adverse effects can cause cytokine release syndrome, can be toxic to your nerves, and sometimes can cause cytopenias. Okay, so we'll progress to the next drug, which will talk about it. For the next drug right here before us, this is what is known as the idecaptagene vicleucel. So this one, the brand name is known as what? Abecma. Okay, you can see the picture. I have the pictures here. So this is what is known as the idecaptagene vicleucel. So this one too is a B cell maturation antigen directed autologous CAR T cell therapy, and it's also approved for the treatment of relapsed or refractory multiple myeloma. So, what is the drug class? It's an autologous cellular immunotherapy. It targets the B cell maturation antigen that's usually expressed on B cells. Okay, that's a plasma cells. So, mechanism, you take the patient T cells out, you mix them with the drug. So basically, the drug what enhances the T cells, so that when these T cells are reintroduced back into the body of the patient, they recognize myeloma cells more. Okay, and they break down these myeloma cells more. Okay, so pharmacokinetics usually introduce them just one infusion, and they start working in about 1 to 2 weeks. So it's been approved for treatment of what? Relapsed or refractory multiple myeloma. Okay. Relapsed or refractory multiple myeloma. So adverse effects can cause cytokine release syndromes and can also cause what? Neurological toxicities leading to confusions, seizures, encephalopathies, and the rest of it. Okay. Idecaptagene vicleucel. Now we're looking at another concern towards gene therapy. Concern is more of like disadvantage. So what makes it that we can actually accept gene therapy 100% worldwide? So this is another disadvantage is gene therapy requires high technical procedures. So in a summary, our normal hospitals that could give normal drugs to people will not be able to what, do gene therapy to those people. So if gene therapy is supposed to actually be implemented, the special high technical places are supposed to be established for this gene therapy stops. So high technical requirements of gene therapy is actually also a major concern. Okay, that's to say that if gene therapy is to be implemented worldwide, then they have to now build some special hospitals all over again just for gene therapy. So specialized vectors. Gene therapy uses viral vectors to be able to deliver the genetic material. So those vectors require advanced biotechnology facilities. So manufacturing them is so costly and technically demanding. So precision delivery. So gene therapy must actually be delivered to the right cells that need it. If they are delivered to the wrong cells, it might actually cause a whole lot of issues. Okay. Patient specific customization. So almost every disease condition you are dealing with as related to gene therapy is special. Okay. So you have to arrange everything to fit the patient and the rest of it. So monitoring and safety protocols is patients must be monitored for immune reactions, insertional mutagenesis, and long-term effects. So infrastructural needs is gene therapy trials and treatments demand specialized labs, clean rooms, trained personnel. So the whole thing is okay, handling the gene therapy, the monetary demand is so high. Okay. So at the end of the time, if government even invest in this, can uh, the citizens be able to afford in paying for services? Do you understand? So that's actually one of the concerns as related to implementing gene therapy worldwide. Now, we also look at another concern as related to gene therapy, and this is what is known as lack of regulatory concern controls. So, lack of laws, that's clear laws that should actually govern these gene therapy procedures. Okay, the laws are not really there. So, this is actually another concern as related to gene therapy. So, uneven global standard. Okay. So first is safety risk. So without strict regulation, therapies may be rushed into trials and clinical use. Okay, and they might not actually understand the long-term effects of those therapies. Do you understand? So they might end up approving something that works now, but later on is a disaster. So uneven global standards. So different countries, there's a way they actually look at gene therapy. Why some countries ban it, some people what approve it. So there's an uneven global standards towards it. Ethical oversight is weak controls can lead towards exploitation of vulnerable population during clinical trials. Okay. Then transparency issues, so lack of mandatory reporting of adverse events may hide risk. So sometimes people might actually do this but hide the buy side of the drug and it might end up being approved and it's causing a lot of harm to the public. So commercial pressures. Gene therapies are extremely expensive. So without regulation, companies may actually prioritize the money they will make from it over patients' uh, safety. Do you understand? So this is why we actually need very strict rules towards gene therapy. And as of the time of recording this video, we haven't actually had good rules that actually govern gene therapy that will actually, uh, guarantee your safety, if you are going to actually undergo a gene therapy or so, you know. So we're looking at the next uh, we're looking at the next drug. That's the next genetic therapy drug, and I think this will be our last for today. And this is what is known as the voretigen neparvovec. Okay, voretigen neparvovec. The brand name is known as a Luxturna. So for this drug, uh, we said that it's a gene therapy is mainly used in treating retinal dystrophy. Okay, so we said that drug class is gene therapy. What vector does it use? It uses the adeno-associated virus serotype 2. So mechanism is used in treating retinal dystrophy, so it's an eye stuff, right? So if you want to deliver this drug, you give it what? Subretinally, okay? So it delivers a gene known as the RPE65 gene. Now that RPE65 gene is very essential for visual cycle. So to restore all transretinal esters, okay, to restore their conversion to 11:6 retinal, which is to now enable photoreceptor activation. So to improve light perfection and also visual function in patients that usually lack that what RPE65 protein. Okay, so it's a single subretinal injection, and just the retinal cells will absorb it, and it works for a very long time. So it's used in treating what? Retinal dystrophy in patients that are lacking the RPE65 gene. So adverse effects can cause conjunctival hyperemia, cataract, retinal tears, and eye pain. Okay, so that's what we have for this last drug which we'll be discussing. And I think